Hi, I'm Andrew. I'm one of the trauma chiefs. Welcome to our trauma center, name unspoken. And I just want to go through how we run traumas in the trauma bay here as kind of an orientation video so you can see it beforehand. So we're just going to go through the primary survey and I'm going to give you some tips and tricks to be more efficient. So the saying, prior preparation prevents piss poor performance is 100% true. This is pretty much how you find your trauma bay when your traumas are going to roll in, and there's a few problems here. First is that there are normally not two beds side by side. Normally there is another patient here, which means that this is closed. As you can see, we are running traumas in small closets. So positioning the bed is the very first thing. There's a problem here because the person who's trying to get to the airway can't get to it. So the first thing you need to do is move the bed out and probably over a little bit to one side so that when the ambulance people come in, they can bring it here and we can have some people to move over. The other thing is this pole is generally here and it's basically just in your way, so you can't get to the airway or people are getting around it. So just drop the pole down completely and drop these side rails too so that now you can have access to hold C-spine and do all your airway stuff. So starting with A is for airway. There are several responsibilities of the person with the airway. So first is to make sure that you have the airway box, which my trusty assistant, Dr. Thomas, will show you. So there are two airway boxes. One is yellow and the other is red. One is technically the ER airway box, which I believe is the red one, and the yellow one is the trauma-specific airway box. Not exactly sure what the difference is between the two. They both have ET tubes and what have you, but go for the yellow box if you have enough time. The other thing you have to do is to bring the glide scope into the trauma bay, which is back like in the inventory room somewhere. That's really important because for a lot of patients who have C-collars on, it's very difficult to intubate them using just direct laryngoscopy. So, number one is to get the airway box. Number two is to make sure that there's suction set up. So most of the time you're going to, oh, you can come in, because I got to show them this. You're going to find something like this, where there's like some piece of tubing, but as you can see, there's no yang tower, and the other tubing is not here. And you don't want to find that out as you're trying to run your trauma. So you need to get your piece of tubing, get a yang tower, and as far as where to put it, there's not a lot of room here, but on the back there's this little hole, so you can just shove it in there with the tubing attached and then you're ready to go. Just have it turned on so that you know it actually works. Alright, so that's airway. Now you have one, your airway box, two, you've got your suction set up. So three, you need to, especially for people who are in extremis or you're going to likely have to intubate, talk to your pharmacist to make sure that they have intubation meds. And this is especially true for traumatic arrest because those people are generally sick. If it's an actual traumatic arrest, then obviously you just intubate, you don't need any meds. But many times they call it out as a traumatic arrest and the person comes in and is not in fact arrested. So the fourth thing that you need to do is make sure you have meds for after the intubation, because there have been a few times where you get the initial meds in, you get the tube in, and then everybody leaves because the exciting part is over. So as it turns out, you still need people here even after the money shot. So basically you want to have drips that are potentially available for you to hang immediately so we can move on with the rest of our survey. Alright, so airway box, suction, intubation meds, and then drips for after intubation. And then the last thing that you want is an OG. While you have the person paralyzed or whatnot, it's best to get your OG in for gastric decompression at that time as opposed to have the paralytics wear off, then try to put the OG in, because then the person a lot of times is bucking or whatnot, and I've actually seen people wind up throwing up because we try to put an OG or NG in after their paralytics wore off. And hopefully they won't aspirate because the cuff is up on the ET tube, but hey, it's not impossible. Alright, so that concludes airway. Okay, we can do there. You want to do a B?
Yeah.